Okay. Oh, well, it's really nice to be able to talk to you from so far away. I mean, here I am in New Zealand in brilliant sunshine on a very, very hot day. And I think it'll be a little bit different with you, but it's wonderful to be able to do it this way. And what I'm going to do is go through an overview, really, of chronic fatigue syndrome, what it's all about, and how best to manage it. And then we'll obviously have questions at the end, and we'll see how it goes. I mean, I've never done a Zoom thing before, so we're all learners. So here we go, and that's what most of my patients look like, and probably most of you will feel like that by the end of this session. But I thought that was quite an apt little picture, really. So what's it all about? Epidemiology really is a word for boring statistics, but we need to just focus briefly on that. And we know for sure that about 3 per 1,000 people get this illness. The illness can be very mild, or obviously very, very severe, with people totally bedridden and often in a darkened room. All age groups, but it's certainly more common in females. We're talking, 70% maybe female. And we wonder too if there are hormonal links. And I think more and more evidence is coming through that is probable. So what is it? Well, the majority of people, the illness will be triggered by some sort of viral infection, but not always, and we'll talk a little about that. There is a genetic vulnerability in that we do see family clusters sometimes, and they have linked the illness to certain genes that have been identified. But just because you inherit the genes, it just makes you vulnerable. It doesn't necessarily cause the illness to be definitely going to happen. Once you've got the illness, there is what we call persistent overactivity of the immune system. And in more recent times, they've identified definite brain inflammation with little white cells in the brain sparkling away. They call them glia. So that's identifiable on a MRI scan. And there is often a major upset in the underlying body chemistry. The microbiome, which is the bowel contents or the gut contents, is imbalanced. And all these things, they're all linked together, and it leads to a variety of symptoms, which I'm sure many of you are aware of. I mean, no two people seem to be the same, and the symptoms often mimic the initial illness that might have triggered it all off. Predisposing factors, again, we could go make long lists, but certainly there is a genetic predisposition, and often in the lead up there will be things like over-exercise, sometimes an accident or surgery, immunizations, toxins. All these things can make you more prone to going ahead and getting the illness. Certainly sleep deficit can play a role too, and many people I see will say things like, oh, I've never slept terribly well, or I was going through a bad patch because I had a new baby. All these things play a role. And of course, almost always there will have been a viral illness, though sometimes may not be viral. It sometimes might have been a bacterial type of illness. And of course, anybody can get this illness, even top athletes. I think people who are pushing the exercise very, very hard, who happen to get, let's say, something like glandular fever, are very vulnerable. So very, very high incidence of this illness in athletes who try and push on through an illness. This is just a little bit more of a complex picture of what actually happens during a infection. And I haven't got a pointer here that I can use, I don't think. But anyway, at the very beginning, if you look down in the bottom left-hand corner, you get an acute episode. And let's say it's glandular fever, or what we call mononucleosis. and the immune system is activated immediately. The bugs are not liked by your body, and so you get that rise in immune activity, which subsides in a month approximately in about 90% of people. However, there will be another 10% that go on with an immune activity that lasts a lot longer. 9% of those will be recovered in about 6 months, and we call that post-viral syndrome, recognized long ago as a complication from a viral illness. And we're going to hear and see much more of it with the COVID thing going on, obviously. And about 1% of people carry on being unwell for much longer than the 6 months. And we call these, then rename them as suffering from chronic fatigue syndrome, or ME. The length of time is variable, so there will be some people recovering in about 6.5, 7 months, and others who go on and on and on. I've got stress there as a sort of complicating factor, really, because every time there is stress, there's a little bit of a surge of immune activity, and that stress may be physical stress, like as the runner I mentioned earlier, pushing the body very hard, or of course it could be the typical stress that we see when people are stressed through some sort of life event. So any sort of physical or mental stress will kind of aggravate the symptoms, let's say, because it gets the immune system a little bit more aggravated. So what is it? Well, it's what's described by a man called Younger, who's a well-known researcher now, as an immune-triggered metabolic disorder with widespread neuroinflammation. Now, that's all a bit medical, but that's his definition, and I think it's very accurate. And there is what we call glial activation, and the glia are those little white cells in the brain, which are inflammatory cells, which have been shown to be very activated during this illness. And this probably contributes a lot to headaches and also to a lot of the brain fog and other neurological symptoms. And when you have an MRI scan done, you can see these little glia sparkling away, and they shouldn't be. So that's certainly a very definite abnormality. The viral illness itself is not usually ongoing. That's usually over and done with. So you might have had chickenpox or glandular fever or whatever, and that goes its normal course and is over and done with, but the immune system remains highly activated, and you get all these symptoms, which many of you will be very aware of. And the symptoms are often quite suggestive of infection, as if you'd still got an infection going on, like maybe tonsillitis or gut upset. But when you have blood tests or stool tests or anything else done, there's nothing to indicate that the infection is still active. So it's completely bizarre situation, really. So how do we make a diagnosis? It's kind of very complicated. It's not simple. There's no easy, quick blood test that you can have done that proves it. So the doctor goes back to old-fashioned principles, really, of taking a thorough history, examining the patient very carefully, doing a blood screening, which is, blood tests and what have you, and then sometimes doing further tests for very specific things, like, for example, if you had a lot of chest pain, you might need to have an ECG or a chest X-ray. And then, of course, a psychological review is important, and people, I find, don't like the idea of that. They think, oh, straight away someone's going to label them a nutcase, but in fact, the reason for a psychological review is twofold, really. First of all, to make sure you haven't got a psychological illness, and secondly, if you have, to treat it, because certainly a lot of people, for example, with this illness, with ME, can get very depressed, And if you have that depression treated, it gives you a better chance of improving. So yeah, we need what we call a biomarker, which is a blood test you could have done, which proves whether you've got it or not, just like you can have a blood test done for thyroid disorders or diabetes. But bear in mind, the majority of illnesses, we don't have a blood test. So this isn't that unusual. Most illnesses, we make a diagnosis according to our kind of longer term expertise or other things that the patient may tell you that says, oh, straight away, yeah, that's what they've got, you know. So it would be lovely to have a blood test, and maybe that's not that far off. Certainly some very good research going on in Australia, in Queensland, which is finding some real abnormalities, and also at Stanford University in the States and so on, all over the place. We're getting close to a blood picture. Even here in New Zealand, in Professor Tate's lab in Otago, they're well on the way. So we complete the diagnosis, we do our history, examination tests, and so on and so on. And then we have to say, does the patient fit the diagnostic criteria? And for this illness, like every other illness in the book, there are a set of criteria that you have to adhere to, a set of rules really, that prove whether the person's got the illness, or near enough prove, give us a very good indication. Having then made a diagnosis, there has to be some sort of ongoing surveillance, watching for new symptoms, because we don't always get it right. And I think that applies to, again, to every illness. We do make mistakes, or we can't be sure always. So we're on the lookout for new symptoms and new pointers. And of course, with this illness, there are whole lists of overlapping conditions, that means things that occur as well. And you will probably mostly be fairly familiar with these things. I won't have time today to go into all of those things, because each of them would need a whole session on its own, but I'm sure you've heard of these things, and particularly top of the list, the first two, POTS, which is the feeling of woozy lightheadedness if you get up suddenly, and fibromyalgia, which is the chronic pain that occurs frequently in this illness, muscle and joint pain and so on. So those two things, very, very common. The others less common, but do occur. So what are the main symptoms? The main symptoms are due to the immune system producing a lot of hormones and chemicals of its own, which leach into certain parts of the body, the brain in particular. Again, I won't go through all the symptoms in detail, because many of you will be very, very familiar with them. And those are not the only symptoms. These are the main symptoms. And this is unfortunately an illness that has many, many symptoms. So when we sort of put a finger in the middle there and see flu-like symptoms, what does that mean? Well, that could be fever, feelings, sore throats, glands up, sinus problems, cough, tummy upset, so on and so on. So under each of those headings there, you would get a whole lot of different symptoms. So the illness can be quite bizarre in that you don't necessarily get all those symptoms, but you probably get enough to make you feel mighty ill. Then we move on to a treatment plan, and I'm not going to linger on this slide too long, because we'll move on to how we manage the various symptoms in a minute. First of all, to say, though, there's no one specific treatment that fits all. Every patient with this illness has to be individually assessed and reviewed regularly. And treatment plan could be quite different for each person. That's because there are so many different symptoms, added to which we are so many different people, so none of us is the same, and this would apply obviously to many, many illnesses too. Very important to treat any underlying conditions, but the general management plan is a very basic, simple plan that we would use for most illnesses, particularly chronic illnesses, stress management, exercise, diet, supplements, hormones, sleep, pain. That's a kind of a good little checklist of things that the doctor needs to be going through in his or her mind in setting up a plan for this patient with this very, very complicated condition. So let's look at some of the symptoms and see how we would manage the specific symptoms. And you'll see that we cover a lot of the different aspects that were on that list that I've just shown you. Fatigue is, of course, one of the principal symptoms, and most people who come to me will say, when I say to them, what sort of problems do you have? They just say, well, I'm just so tired all the time. So fatigue is probably the most overall common symptom throughout all the different variations of this illness. The difference is from ordinary everyday fatigue, that the fatigue is worsened by exercise, overexertion, stress, and it's not relieved by rest. So, you know, if you're tired because you've been for a long walk and you're a healthy person and you come home and you lay back and have a cup of tea, you feel right in a half an hour. With this illness, the exercise or exertion tends to have a very prolonged ill effect. Very important to get plenty of rest and sleep and a nice regular kind of routine, and to pace yourself very, very carefully. And pacing is the right word to use because you need to do things in small bursts rather than trying to do, you know, clean the house all through because you happen to feel a bit better today. You're better to do one very, very small amount, banking your energy and using it bit by bit. Also for fatigue, you do need to eat. And we find that many, many people with this illness either can't be bothered to eat, or they've got no energy to cook, or they've got no energy to shop. And so eating can become a little bit erratic and sporadic. So really important to be looking at regular intake through the day. You do much better to have small bursts of food rather than a great big one big meal. One big meal sits like a great big blob in the middle of your belly, and it's very, very hard for your system to digest and deal with, and you don't get much energy from it. You can feel quite ill. But if you have small little tiny amounts through the day, lots of snacking between meals, you do absorb them more speedily and get bursts of energy more readily. So little and often is the way to go. Then, of course, as part of your fatigue management, you do need to be seeing a doctor or health professional from time to time and making sure that the diagnosis is correct and there are no other reasons, blood tests to check for iron levels and so on. And also bearing in mind that fatigue anyway gets worse as we get older. You know, we run out of steam more readily. So there are all these kind of compounding factors, really. So what's post-exertional malaise? That's considered to be one of the core symptoms of this illness. It means that if you do anything exerting yourself, be it mental or physical, but particularly physical activity, you become really exhausted quite quickly usually, but also that can all be delayed for a very long time. Sometimes the ill effects from too much exercise don't occur till the next day or even 2 days later. So you need to recognize post-exertional malaise and do everything you can to prevent it, really. And that means learning to pace yourself very, very carefully, keeping your activities very minimal. So you might find that you can barely do a 2-minute walk, but that's your starting point. You do 2 minutes every day. You don't try and do any more. And then if you've managed to keep that going for a week or two, you could put it up to 3 or 4 minutes, but not suddenly to 15. So you never push hard. You learn to balance your activities, work out what has to be done, get help if need be, and so on. And bear in mind, if you are able to exercise, or not if you are, when you are, it should ideally be sometime outside. I don't know what Ireland's like at this time of the year, but certainly you need a little bit of fresh air and sunlight if possible, because this is how we metabolize vitamin D. And if your vitamin D levels get low, then you tend to be very much more tired. So getting outside for 15 minutes each day, wrapped up warm but with face and hands exposed, is a worthwhile exercise. And then there's a supplement. I'm not going to talk a lot about supplements today because there are not many that really do have proven research to back up their use in this illness. But coenzyme Q10 has been shown to help with some of the myalgia, which is the medical word for muscle pain. That should be taken in the morning, and for some people it has got some benefit. It's quite expensive, but worth a shot. Sometimes you can try something like this and you can't quite be sure, but then if you think, right, well, I've been on this a month, I'll see how I am without it. And if you stop it and you go downhill, you know it's been helping you. So, look on supplement management that way, really. Okay, cognitive problems are brain problems, really. And you've all heard the saying, use it or lose it. And that's very, very important with brain activity. But again, it's like using your muscles, little and often, regular rest, pacing. Overstimulation can be a problem, say bright lights and noise and so on, all these things. I mean, supermarkets about the worst place to have to go because there's the light and the stimulation and the noise and clattering and a lot of walking and so on. So you want to get help for things like that if you possibly can. Fresh air I've mentioned, and certainly a lot of the relaxation strategies that we hear about, very worthwhile exploring. Everybody's different, so it's no good me saying, okay, everybody get into meditation or mindfulness. Much better to search around and choose your own route to relaxation. And it might be deep breathing, listening to music, might be something like Tai Chi or yoga, but whatever you choose, have a go. And if you don't like it or it doesn't work for you, move on to something else. I'm not saying these things are going to cure your illness, but they will certainly give you a better chance of avoiding relapse, and that's a big, big issue. And B12 injections have been shown to be useful for people with this illness from the point of view of improving some of the brain function. A lot of that research came out from Iceland, and they have shown that the B12 level in the fluids surrounding the brain is quite low in some people with this illness. So it gives us justification for a course of B12, which seems to be very safe and has been around for a long time. And I usually prescribe something like 1 a week for 6 weeks, and probably about 70% of people will notice some benefits. So again, something to, excuse me, look into. Okay, this so-called POTS, or orthostatic intolerance, excuse me, what is this? Well, it's the issue that when you stand up very suddenly, you feel quite woozy and lightheaded, and that's because you haven't got quite enough oxygen or blood getting round your brain. Everything seems to fall into your feet. It's a sort of postural gravity thing, really. And so it's really important, if you get that set of symptoms, which can be quite unpleasant, and some people even faint, you change your position very slowly. You get up slowly. Going to the hot shower can be quite trying. You don't want to be upright for too long. These sorts of things help you cope better. And some people use what we call compression clothing, which is tight elasticated stockings, things like that, which can help to sort of keep the blood flowing in the upper part of your body rather than falling into your feet. Extra salt has been shown to be really important, and we are talking through the day, not just with your evening meal. And of course, it's important to check that you have normal blood pressure and no reason that you shouldn't have salt. But most people with this illness do have low blood pressure and can tolerate salt quite safely. And we're talking of getting salt, probably a good pinch of salt or an electrolyte drink every couple of hours through the day. You can have salty snacks like salty nuts or crackers or whatever you like, chippies, or you call them crisps, I think. They're very, very useful for giving you a quick fix snack. So go for the salt in a big way. It's one of the few illnesses that we recommend extra salt. And some people go on to medication called fludrocortisone, which helps the body retain the salt. That needs to be fairly carefully monitored. And certainly, I've heard quite a bit in America, they're using intravenous infusions of saline. And for some people, that may be an option, but IV infusions are not ideal. They're inconvenient and not always safe. So I think it's better to just eat salt. Cheap, easy. Then exercise is often easier for people with this if they're lying down. So swimming is very suitable in the summer, or a nice warm pool. Again, don't be pushing yourself hard because you happen to feel a bit better that day. Better to just do a small amount and play around in the water rather than trying to do lengths or anything like that. The flu-like symptoms are not an infection as such usually. Sometimes when you are almost recovered, however, you may suddenly be saying something that I've often heard said, oh, I know I'm getting better because I've had a proper cold. So the kind of flu-like symptoms you get with this illness are quite different to an ordinary cold or flu, and they're due to the overactivity in the immune system. Things like antibiotics and vitamin C don't do anything much at all. And I think the important thing is to identify the symptoms of being a kind of mini relapse, really, and needing to rest up and give in to it, as if you had a real attack of flu. Sometimes anti-inflammatories and things like Panadol and aspirin can help a little bit, and certainly saline saltwater gargles are quite useful. But the main thing would be rest and giving in. Pain, fibromyalgia, headaches. Well, pain we could spend probably 2 whole sessions on, and we're not going to be able to do that because pain is a very big, complex subject and very much part of this illness. And there are, of course, many, many different types of pain. Always you start with the simple stuff. So rest is important if you're in a lot of pain. Sometimes you've got no option. Warmth and massage, sometimes things like lavender oil and nice surroundings, relaxation, that sort of thing, really, really important. And to avoid the triggers. Often the pain will be brought on as part of the post-exertional malaise, overdoing it. And looking at stress in particular, because we know for sure if we get stressed, all our muscles tighten. Even though we're not aware of our muscles tightening, they do tighten up. And when your muscles tighten up, you feel more pain. So learning some good stress management technique, again, I can't reiterate enough on that. You might find routine painkillers are there on the shelf, but they don't help much. Things like Panadol, aspirin, some relief maybe, but not a great deal. And so we move on to more elaborate pain relief. We want to keep away from morphine and drugs of addiction, obviously. But gabapentin and pregabalin are sort of cousins of anti-epileptic drugs, really, and they're not habit forming. And we start them with very tiny doses and build up. And for some people, they're very, very, very useful. Other people will say, no, I didn't like that drug, I had side effects. And again, we're all different. So what suits one doesn't necessarily suit the next. So you don't take the pills from your next door neighbor, ideally. LDN is low-dose naltrexone, and there's been a lot of talk about that lately, and I can elaborate more on that later on in the talk, but certainly I've got a lot of patients now trying this in a very small dose, non-habit forming, and it can have benefit. I wouldn't say it's the be-all and end-all, but for some people it's useful. And the other thing which I could add to that is cannabis oil, because here in New Zealand we're allowed to prescribe that now. Not that I've used it much at all, but there will be some patients who have found it useful. However, mostly for pain and fibromyalgia, headaches and what have you, we do focus on sleep management because that's really, really important as a means of overcoming chronic or very acute pain. Then we come to gastrointestinal disturbances, which are very, very common in this illness, extremely common. And many people will say that their illness started with a gut infection of some sort, food poisoning or Campylobacter or something like that. And that needs to be investigated thoroughly to make sure it's been properly treated. I mean, you get people who travel, not at the moment, we don't travel much, but there's a lot of travel overseas. You pick up things like Giardia, and these things can be treated, but they can leave you with all sorts of symptoms, particularly if they're not treated properly. There will also be some people with ME who have a lot of problems with food intolerances and allergies, and these things can be checked out, again, sometimes with skin tests or blood tests or giving you something to try and see if you react badly and that kind of thing. So having found out any particular food problems, it's obviously important to avoid those things, but not to get to the point where you start avoiding so many things that you end up eating almost nothing. And I've seen that in the past. I've had one patient I remember years ago who was living on rice and water, and God knows how she survived, but she somehow did for a while. So, you really need to make sure you get variety, and there has been no specific special diet, no one diet that's been shown to be useful in this illness. So again, don't go mad and try the latest just because someone else got better on it, because it may not suit you at all. So, looking at the food options are very, very important. Hormonal issues are an interesting and important area, particularly for females, and it's 3 or 4 to 1 females to males. And you notice particularly, and you look back over the years, as I do from time to time, that often the times when people have problems are certainly adolescence and menopause, and even through the monthly period cycle. So a lot of women will say they feel drained and dreadful after their period. That may be because they've lost a lot of iron, or they feel really bad in the lead up, and that's perhaps because of that sort of premenstrual fluid retention and things like that makes them feel very unpleasant, don't sleep well. And so for these issues, we always look at whether hormones are going to be useful, and estrogen, which is in the pill, and hormone replacement has some positive benefits in this illness for some people, probably more people than not, and certainly not for the men, obviously. But the estrogen can have improvement in brain blood flow. It helps with some of the immune system overactivity and can be quite useful for joint pain. So not to be abandoned. It's something to think about. You find also quite a lot of women have endometriosis who also have chronic fatigue syndrome. So those two hand in hand things go together quite often, and there may be some sort of genetic link. And then, of course, the pregnancy issue is another one. And many, many women do very, very well in pregnancy who have ME. And these women, we can't necessarily predict, because there will be some that pregnancy doesn't agree with. But if you want to have a pregnancy, you choose a time when you're at your best, and the chances are you will do very well through the pregnancy and may stay good. So it's not an absolute no-no. And when we come on to probably what's one of the most important issues of all, which is the effect of sleep. And I won't linger too long on this, else we'll run out of time. But sleep management is really important. And that diagram there is just to show you what happens in a normal sleep cycle. So you go through 2-3 phases of deep level 4 sleep, and 2 or 3 phases of what we call REM sleep or dream sleep. And what they find in people with this illness is there's a sort of loss of sleep architecture. You don't have such dramatic or good ups and downs. And during these various phases of sleep, you produce all the hormones and chemicals that have healing effects on your body. So if your sleep is rather ragged or flattened, you just don't get that healing effect, and you wake up sometimes after many hours not feeling at all refreshed. And that's the typical story with people with this illness. So what can we do about it? And I mean, there's no quick fix. Sleep's a big problem for many, many people the world over with all sorts of illnesses. But these things I've listed there are the obvious things, really. A good routine is absolutely essential. Some exposure to daylight is important, because shift workers who don't get proper exposure to daylight don't produce the melatonin, which helps with sleep. Need to avoid caffeine after midday. Wind down slowly and turn off all those screens, computers, and so on. A snack at bedtime has been shown in some of the research that came out of Finland recently to be helpful. So a very light snack in that last half hour before you put the light out, coupled with a magnesium supplement. Again, this is another supplement that has been shown to have some particular benefit. Then you move on maybe to medication, which for many people is needed. I won't again go into it in a lot of detail, because again, everybody's so different, so we can't pick out one thing and say, well, that's the one for everybody. But the tricyclics, which are things like amitriptyline and nortriptyline, probably top of the list, because they do improve the so-called architecture of your sleep, the ups and downs, taken probably up to 5 hours before bedtime to have maximum benefit, because in this illness, everything's on go slow. We also say avoid the benzodiazepines, which are the traditional sleeping pills, which are habit-forming, things like zopiclone, oxazepam, lorazepam. So certainly we try to avoid those if we can. Many people with this illness do have restless legs. In other words, they can't keep their legs still when they get into bed. For someone who's never had that, that might be hard to understand. But there will be some people who just can't keep their legs still. And we have a drug called ropinirole. And then muscle relaxants can be helpful. So we sometimes use another drug called orphenadrine, or its common name here is Norflex. And these things are they've all got a place. There's no one size fits all with this. We have to really work hard on trying to work out the most suitable medication for sleep disorder in this illness. And it's a big task, really, but it's probably the most important task of all in our overall management of this illness. Okay, so what are ongoing issues? Well, we certainly want to avoid relapse because there will be many people who are doing quite nicely, feel a bit better, think, oh gosh, I'm so good, I'm going to go and play tennis. And then what happens? They spend 3 weeks in bed. So that burning out is very, very common. People gradually learn. I'm sure you've all been there, done that. You gradually learn what is manageable and what's to be avoided, but avoiding relapse is important. Having a regular review by your health practitioner is important, because just because you've got one illness, unfortunately, doesn't mean you can't get another. So we want to be really sure that you're having your regular smears and prostate checks and routine blood picture and so on. And often, ideally, because this is such a complicated illness, you need to be looked after by what we call a multidisciplinary team. Someone looking after your teeth and your eyes and your cervical smears and your breast checks and so on. And then we look at recovery rates, and that's a little bit hard to comment on because the statistics are done in different parts of the world in different ways. But the one I often quote will be Catherine Rowe, who is a paediatrician from Melbourne, and she has very good recovery rates from her very big clinic, which she has for children, up to 85% of children recovering well and getting back into their normal life again. Again, a very, very intense management program, often over a number of years, but she does have very good results. Other factors we would look at, immunisations, are they wise or not? And that's a big one coming up with the whole COVID thing. There will be some people who say their illness began with an immunisation, others who say they had a mini relapse after an immunisation. So it's something to be aware of and watchful and, choosing carefully, really. Pregnancy I've already mentioned, and the COVID long haulers, they're this new group that's going to be coming into our world, if you like. And I think the only good thing for this is that it's going to open up a huge amount of research, which may give more answers. Money will be poured in, no doubt, in time. So hard though it is for the people who've ended up with that illness, it's going to have some positive spin-off for the ME world. Then we come on to what might be the long-term risks for people with this illness. When you have the illness, over time, your so-called natural killer cells may decline in ability and number. This may or may not happen, and certainly some of Nancy Clammis's work in Miami has looked at this quite widely, and they have thought there's potential for an increase in cancers and infections. So you really, again, need your ongoing surveillance to watch for change. There's no real proof that this is absolute, but it's a warning. And then there's also likely to be a slight increase in the blood cancer called lymphoma in people with this illness. Again, the statistics are not absolute, but worth thinking about, worth mentioning. And then you have these telomeres, which are part of your chromosome. We all have many, many chromosomes and genes, and the telomeres are just little stalks involved in that. I mean, I'm not a geneticist, so my science of it's very minimal, but these little telomeres are said to shorten a bit more rapidly in people with ME, which means you may age a little bit sooner, which is rather a depressing thought, but it's probably not going to shorten your life. You might just get a bit more wrinkly. These things have shown up in some of the research. We also know that if we don't treat sleep deficit, this can shorten our life and increase our risk of dementia. So treating the sleep is really, really important. But bear in mind, this is not a degenerative disease. What about the effects on our life? Well, again, I could spend a lot of time talking about the isolation, the losses, the depressive things that go on when you have any chronic illness, but this one particularly because we don't know what the outcome is going to be for any individual. So some people recover quite spontaneously and unexpectedly. Some people get better in quite a short time, like 3 years, if you call that short, but it is. Other people may get worse over time, others get better, others are up and down. So it's a total unknown, and I can't comment very much on all that. There's also the fear that, have I got the diagnosis right? And how will I be from day to day? Can I plan to go and see Aunt Mary tomorrow, or will I be in bed all day tomorrow? And all these things, of course, can make you feel very, very depressed and down, understandably. Important messages, however. All the symptoms you have can be aggravated by stress, over-exercise, activity. We've said that and we'll say it again and again and again. So you've got to pace yourself carefully. Daylight exposure outside, really important for vitamin D, melatonin release, general well-being, clean, fresh air and so on. And then practicing regular relaxation. I can't stress that enough. I'm not saying this illness is all in your head. What I'm saying is these things will help you cope with the illness better and help prevent the risk of relapse. And I won't go through all those things, but I will mention pets because many of us here will have pets of one sort or another, and they have shown that animal therapy is really powerful. Animals give you company, a reason to get up, and if you stroke an animal or cuddle an animal, the animal releases endorphins and, kind of purrs contentedly, or whatever animal it happens to be. And at the same time, the contact with your skin helps you release endorphins too. And when you release endorphins, you feel more relaxed and calm and cope better with the stress and the horrors of this kind of illness, really. So that's important. So what do we need to do? We need to watch always for other illnesses. It's very easy to deny and think, oh, well, it's just all part of my ME, but it may not be. So always report new symptoms to your doctor or health practitioner, get them properly investigated, and make sure you do have regular surveillance of all your everyday things as well. You don't neglect your health. Check your blood pressure, your smears, your prostate, and what have you. Okay, well, as you get better, you begin to feel this false sense of security. You overdo it and you risk relapse. So let's shout pacing, pacing, pacing. And that way you hopefully will begin to feel better and feel more in control of things. Because I think it's fair to say that all patients can experience a better quality of life with compassionate care and a multidisciplinary approach. And you need to feel in control of your health rather than being controlled by the disease. So you take over. You don't let this horrible disease take over your life. And that's how we usually recommend people should rehabilitate. If you've ever read the story of the tortoise and the hare, you'll know what I'm getting at. But the main thing is to go slow, because the tortoise won the race, the hare fell by the wayside, and that so often happens in this illness. And just a couple of resources, I can leave that up on the screen for you. Physicians' Primaries is a good resource, both of these, but good resources both for you and for your GP or other health practitioner. The Physician's Primer was written by the International Association for CFS and is available through their website online. It's about a 20-page booklet, and the Pediatric Primer is available through that rather complicated website. But again, it's about 20 pages. It's pretty readable. I was certainly involved in the work on both of those with various other clinicians from around the world, and we need to update them, of course, in light of current research and what's going on. But certainly they're good things for your doctor if you can download them and pass them on. Okay.
Just to say, first of all, I think you've covered a lot of the aspects of the questions in your talk already, and maybe we could group certain points that have been made on certain topics as well. So if we could take the COVID aspect first, there's been a couple of questions in on the COVID, the link. So I'm just going to put these three to you together, and whatever way you'd like to answer them then will be fine. Okay. So the first one is, do you believe it's possible that the symptoms post-infection are going to get better with time, or do you think there's a possibility the effects could be long-term? So that's one question. The other one is more about the vaccine. Is the COVID vaccine likely to have an adverse effect on ME sufferers? And this person began with a viral infection 41 years ago, they say. And another person again says, is it safe to take the vaccine, especially for somebody with long-term ME? So two of those questions are about the vaccine, and the other one is about symptoms long-term, etc.
Yeah. Well, I think first of all, as I said just now, I mean, people with COVID, there will be a percentage that go on to remain chronically unwell afterwards, the so-called COVID long haulers. And as far as we can see at this stage, it's probably a very similar kind of illness to ME. Again, it's very hard to know. I've actually seen 4 patients already with the so-called long COVID, and their illness has been very, very similar. But of course, a lot of these people may well recover much more quickly and efficiently. We just don't know. Others, of course, may last for a very long time. But I think, you know, to all intents and purposes, COVID is a virus. And most people with ME, their illness would have started with one virus or another, you know, be it glandular fever or flu or even a cold. So I don't think the COVID is going to be any different, but the symptoms may again be more related to the individual person's initial illness. And I think we find that with ME too, so that if your illness started, let's say with flu, your symptoms can be more flu-like ongoing. If your symptoms started with gastroenteritis, then again your symptoms might be bowel and stomach related ongoing. So same might apply to the COVID, depend on how or what sort of illness they had to begin with. But I think we are looking at something that to all intents and purposes is going to be the same. Regarding the vaccine, there will be people with chronic fatigue syndrome, ME, who have had bad reactions to other immunizations in the past, so they will naturally be wary. However, we know for sure COVID is a nasty illness, and just because you've got ME doesn't mean you potentially could catch it. Again, you're probably, many of you, living fairly sheltered life away from the hubbub of people with infection. So, you know, your risks are perhaps lower. In fact, who knows, the chronic fatigue syndrome may in fact protect you against a little bit about COVID, because we know for sure, as I said earlier on today, often people with chronic fatigue syndrome will say things like, I knew I was getting better because I got an ordinary cold. So there, we don't really fully understand what's going on in the immune system. But Charles Shepherd, who's British doctor involved in the British ME Association, sent me just a few days ago a very good handout that the British people have produced on COVID vaccine for people with ME. And, you know, it's very readily available from the British ME Association. It's a very, very good handout, quite readable, giving you the pros and cons of whether you should have the vaccine or not. And if you do, you know, what precautions you might like to take. But I think it's about the same for everyone. Any vaccine puts one a little bit temporarily at risk. So you choose a time, if you're going to have it, when you're at your best, and you allow a few days of total rest afterwards to allow yourself to recover properly from any potential ill effect from the vaccine. So I don't know if that answers your question, but certainly that would be my comments on that, really.
Okay, thank you. A separate question then. Are you aware of research that suggests that as many as 36.1% of women with endometriosis qualify for a comorbid diagnosis of ME? And could you suggest a common precipitating factor, or might it be a genetic predisposition?
Well, I think certainly I've read in the past research that has shown that the genes that relate to ME are often closely related to things like endometriosis and migraine and irritable bowel and some of the overlapping conditions. So I don't think I can give you an absolute answer on that to say, except they are often commonly related. And one of the reasons also that it's all likely to be thrown into the same basket is that endometriosis is an inflammatory condition. So for those of you that don't know, it's a sort of inflammation of the lining of the womb, and these bits of womb get deposited sometimes against the bowel and other organs in the lower abdomen. So women with endometriosis get a lot of pain, but it's very much an inflammatory condition. And if you've got ME, any inflammation in your system is likely to aggravate. And in reality, if you and again, this is just my opinion rather than based on research, if you've got an inflammatory condition that is not being treated or can't be treated, that may just be aggravating your ME and stirring up the immune system even more. So if a woman has endometriosis, I would always recommend that she tries and gets it treated as best possible.
Okay, thank you. This is a fairly general question. Are there any new drugs or therapies worth trying?
Okay, well, again, you know, I mean, I could list a whole lot of drugs that might be worth using or trying, or therapies, but the ones that stand out at the moment for me, and, you know, I'm kind of going on what my patients are asking or interested in, would certainly be the low-dose naltrexone, which I mentioned during the talk. And there's been a lot of talk about low-dose naltrexone. Naltrexone's a drug that's very, very old-fashioned. It's been used usually in the past to treat people who have severe drug addiction, you know, heroin, morphine addiction, that kind of thing. And it's used to help them get off the drugs. And we're talking then very, very high doses of, you know, quite a powerful drug. But what the rheumatologist found a few years ago was that very small doses of naltrexone helped people with fibromyalgia, the pain of fibromyalgia. So they did a pilot study looking at that and found that the sort of anti-inflammatory effects, which are part and parcel of the effect of naltrexone, were quite useful in controlling pain in those with fibromyalgia. So they furthered their studies, and the studies have grown. And it's certainly a drug that's got use. I use it quite a bit now. We would say if you, and again, these are just sort of out of my head figures, nothing specifically researched, but about a third of the patients I try on this would benefit, either with pain relief or certainly sometimes sleep and just general well-being. It's not curing the condition, but it's helping. About 1/3 will be a little bit unsure, not quite sure whether it helps. Maybe it helps a bit, maybe I'll persevere. You know, those kind of comments come through. And about 1/3 will say, no, it did nothing for me. And in fact, I even felt worse, some of them will say. So it's like most of the drugs that come into use for this illness, there will be the group who don't seem to benefit through to those that seem to benefit a lot. Fine, for some people it does cause insomnia. The majority it helps with sleep, but for the small group that causes insomnia, we get them to take it in the daytime because they get some sort of daytime stimulation from it. Those that benefit sleep, of course, will take it at night. So I think that's an important consideration in the sort of armamentarium of possible drugs. And what they've found is the naltrexone probably quietens down some of that sparkly brain glial activity. So there's help there. And the Queensland group, led by Sonia Marsha-Grodiznik in Queensland at Griffith University, have found that the low-dose naltrexone improves the way that calcium moves in and out of the cells in the body, and that's considered to be a very important aspect of how and why it works. So they are enlarging their studies into that drug. Another drug that I use not very frequently, but reasonably often, I suppose, would be nifedipine or nimodipine. These are drugs that improve brain blood flow. They're used to treat blood pressure, and they have the disadvantage of lowering the blood pressure a little bit in a person who's already possibly got this POTS, but they can improve the circulation to the brain a little bit, which can be particularly useful for people who are maybe needing their brains for study, students and people like that. So that's an option. Again, I haven't used it very often, but I do have a few people who seem to benefit from the neurological drug called Mestinon, which is used to treat a kind of similar illness called myasthenia gravis. And Mestinon in small doses has helped a few people. But I think, again, we come back to the old story that everyone with this illness is very, very different. And focusing on getting sleep medication right is very important, and obviously pain relief, because if you can be relieved of pain and sleep well, then your whole quality of life is going to be better. Yes. There are obviously other drug trials going on around the world, which I wouldn't pretend to know an awful lot about, but certainly the work is going on out there, and that's the encouraging thing.
Sure. This question now is very similar, and you may have just covered it, but is there any medication or natural substance that improves the brain fog? I assume you probably say LDN again, maybe.
Well, LDN, yeah. The LDN and the nifedipine that I mentioned, or nimodipine, to improve brain blood flow, and also the fludrocortisone, or Florinef's its other name, very useful for retaining salt, because if you retain salt, you get better brain blood flow. So, people take Florinef, and you have to take that every day, and sometimes twice a day, and it needs to be monitored fairly carefully to check that your electrolytes, your sodium and potassium and things are keeping in right level.
Yes. Okay, thank you very much. I have another one here now. It relates to inflammation, if you can say something about this. The questions are, if an MRI scan showed inflammation, can a GP treat this? And does energy increase when inflammation is decreased? And does increased inflammation mean the immune system is being attacked?
Okay, well, I think I couldn't quite get the beginning of your question, but you're meaning inflammation in the brain?
I expect so, yes.
Yeah. Well, certainly they have shown these white or sparkly cells in the brain, which is a sign of brain inflammation. And that's all part and parcel of the illness, really. And the illness is characterized by an inflammatory response. In other words, the immune system is very, very active, very highly active, and those brain cells that they've identified are all part and parcel of that. Anti-inflammatory anti-inflammatory drugs don't really seem to have much obvious benefit, except sometimes in pain relief. So you might go on to ibuprofen or Voltaren or something like that and get some pain relief because that's the effect those drugs have. And aspirin, of course, is in that category as well. But the whole condition of the overactivity of the immune system is not generally improved very much with anti-inflammatory medication. So the anti-inflammatory drugs do have a pain-killing effect, however.
Okay, thank you very much.
Okay. I've got a couple of questions here that I could address, if you like, on the list. Yeah.
Sure, absolutely.
Someone asked the effectiveness of licorice as a supplement, and I would say that's very worthwhile. Licorice is a bit like the salt. It improves the retention of the salt, or at least it works in a slightly different way, but it improves the brain blood flow and the blood pressure a little bit in the people with POTS. So yes, licorice is worthwhile.
Oh, very good.
You know, if you enjoy licorice and you can chew it regularly, you might get some benefit. But just bear in mind, if you have a lot of licorice, it can upset your bowels. So, you know, give you diarrhea because it does have an opening effect. And then another question here was women's health and fertility. Should that be managed in a specific way? And I think it's fair to say that this illness does not affect one's fertility. So contraception is obviously important for those that might need it. Or avoidance, of course, but fertility, the opposite. You know, when people are trying to get pregnant, there's no reason at all why they can't have the investigations and medication that might improve their fertility. If anything, I've had a number of women who've been through in vitro fertilization, and they've actually done very, very well with the hormones that have to be used. So there's no real bad issues about that. And then someone else asks if what are the differences between mild, moderate and severe cases of this illness? Well, again, I probably don't need to enlarge much on that because it's fairly obvious, but there will be the group of patients, probably about 5 to 10% who are very, very mild. They're still able to work and go to school or study or whatever they're doing and lead a very normal life, but they're very vulnerable. You know, the slightest little extra or push can tip them over the edge. So they are probably a very much at risk category. I often say to people, the danger zone with this illness is when you're nearly better, because you very easily can push it hard and overdo it. But then, of course, you've also got the other end of the scale, which is the very severely ill people who are bedbound and often in a dark room, unable to do very much. And they will often be people whose initial illness was very, very severe, not necessarily, but often, and they've never really come out of that bad patch. But again, I've had people who for no apparent reason have started to get better when they've been very, very severely ill. So I always tell people, however bad things are, there's always hope. Also, if you're at the top end of the scale and nearly better, just remember you're in the danger zone, a bit like being near the top of Everest, you know? You're not quite there, so you've got to be very, very careful because it's getting more tricky.
There was another question here. What percentage of patients recover 100%? And thank you for the IV information.
Okay, well, again, it's very hard to measure who's 100% because we all get older, so we lose a bit of our health as we get older. And, you know, I've had people who've been rugby players who've, you know, started to get better and wonder why they can't play rugby at 40, you know. So there's every sort of level of how much better can a person get. I have certainly seen people who've recovered seemingly completely, as has Catherine Rowe, who I mentioned with the paediatric clinic in Melbourne. You never know for sure if a person has totally recovered or whether they might relapse one day. But I have had a lot of people who have recovered and done very, very well in the long term. Obviously, excuse me, a lot of people who haven't recovered. But I think one has to live with hope. I think a lot of people manage their life much more efficiently when the more they learn about the illness. And if you manage your life efficiently and sensibly, you can begin to live a much more normal life. I think, you know, the reasons that people often don't improve, and I'm not saying recover, but I'm saying improve, is because they are depressed and lonely. So it's been shown in the statistics that people who have a really good network of people around them often do better. Older people don't recover so well, and that applies to absolutely every illness because our powers of recovery get less as we get older. People who are in very bad relationships, you know, poor marriages or very unhappy relationships, they will often not recover well, again because of probable depression. And you get sports people, they're a big group who really have an awful job to recover because every time they feel a bit better, they're out there pounding the pavements or doing their rugby training or their tennis matches or what have you, and they just keep going down like a lead balloon. And people who are very, very severely ill are less likely to recover well, whereas the people with mild illness, you know, have better chance. And I think the other thing to say with this illness is that we're not just looking necessarily at one illness. We're looking at an umbrella term, which we're calling ME or chronic fatigue syndrome. So you've got this kind of umbrella under which there are all these different subcategories, and we may well end up in 5-10 years time of not calling it chronic fatigue syndrome, but a number of different illnesses. And this was kind of reiterated a bit by Professor Jonathan Kerr from London. He did some work probably about 8-9 years ago now that showed that there were in his studies 7, maybe 8 different subcategories of genetic codes of people with this illness, and the genes related to the different sets of symptoms they had. So that work is very much ongoing. He's still working in that area. So I think, you know, we're going to learn more and more as research moves on, and we're lucky living in an age where they have an incredible array of equipment to do a lot of the testing, things that were unheard of when I was a medical student many, many years ago.
Okay, there's another question here. ME with overactive immune system and weakened body, are we in high risk group for COVID?
Okay, well, that's an interesting question because I suppose we could say, quite honestly, nobody really knows. The chances are that with the kind of overactive or high activity of the immune system in ME, that there's less risk of COVID. That sort of would be a nice theoretical thing to be able to say. However, we don't know enough about COVID to know that yet. And there will be the people with ME whose immune systems have become a little bit more normalized over time. They're not so active with their protective mechanisms. And one thing I mentioned earlier on were your natural killer cells, and your natural killer cells have been shown to be very busy in the early stages of the disease. These are the cells that kill off infections and cancer cells and things like that. So those cells are very, very busy early on. But because they're so busy, over time, the natural killer cell count tends to go down. And this has been shown by Nancy Klimas in Florida and the team in Queensland. And if your natural killer cell count goes down, or if your natural killer cells become less efficient, you become more prone to infections. So this is, again, I don't think the statistics have been done and it hasn't been looked at enough yet, but it may be that people who've had ME for a long time are going to be more prone to COVID because of their poor natural killer cells, whereas people who've only just been diagnosed, maybe had ME for a year or two, are going to be less likely to get COVID. But that's just coming out the top of my head. That's not based on any solid research or anything. It's just beginning to put two and two together, really. I think the main thing is to protect yourself as best you can against COVID by doing all the usual, hand washing and distancing and keeping out of crowded places and so on. Protect yourself all the time, and that's not just against COVID, but against other diseases as well, so that you don't add fuel to the flames of your current health situation.
Okay, so is there a way to kind of keep these levels of natural killer cells up?
Keep what up, sorry?
The natural killer cells, you said were different.
Oh, the natural killer cells, right. Well, again, I think, it's a bit of an unknown. And I think the way to keep your immune system as healthy as possible is to keep yourself in other ways as healthy as possible. In other words, there's not an awful lot sometimes we can do to get rid of your ME, but we can make sure that we keep healthy in other ways by eating properly and trying to get good routines established, good sleep, plenty of fresh air. In other words, looking after yourself and watching for other illnesses and treating other illnesses efficiently. I mean, I know people with ME who, for example, might have a whole lot of boils or something like that. I mean, I'm just picking this out of a hat. And they frightened to take antibiotics in case they get bad reaction to the antibiotics, where they're far more likely to get bad reactions to ongoing boils. So, you have to use common sense and seek advice if need be, and weigh up the pros and cons for yourself and not be too scared of medication. I've had other people who've perhaps needed antibiotics for some sort of chest infection or something, but instead of taking the full dose of amoxicillin, they've taken a few grains out of the capsule thinking, oh, well, anything's better than nothing, but actually they're doing themselves harm because they're really not treating the thing properly, and they're building up potential resistance to the way that antibiotic could work. So I think you've got to, again, use common sense and seek advice.
Okay, there's a question here from Lisa. She's wondering, how much vitamin D supplement do you recommend? She said she's a long hauler, COVID survivor, and first got sick in March. I've already been, sorry, my screen is after, already been supplementing, but wondering if it's enough.
Well, if your vitamin D gets low, you do feel much, much more tired. We know that. And I actually had a woman the other day who had rock bottom vitamin D, and, she was exhausted, but now she's on it, she's feeling better. So it's a little bit of a hit and miss, how much an individual needs. And of course, we need sunlight on our skin or daylight on our skin to process vitamin D properly. So getting outside every day, if it's warm enough, or wrapping up, leaving a little bit of skin exposed, is really important. But here in New Zealand, for example, and I think it'd be much the same in Ireland, in the winter, we recommend that people with this illness take vitamin D, and in the summer they can ease off. And of course, concentrating on making sure you get foods that are well endowed with vitamin D in your diet, things, you know, that are going to give it to you more naturally. So I think it's very important to have vitamin D in the winter, but you can, because it's a oil soluble vitamin, it is potentially possible to overdose, but it's very, very unlikely.
Okay, so there's another tips to avoid cancer in people with ME, and what about anxiety?
You mean avoiding anxiety, or?
Well, it's the first question was tips to avoid cancer in a person with ME, and the second question was dealing with a lot of anxiety.
Okay, all right. Well, tips to avoid cancer. I mean, I think unfortunately none of us can guarantee that we avoid cancer. It's out there, isn't it? And, you know, probably very, very common. There are many cancers through from the very simple little everyday skin cancers we call basal cell cancers through to really vicious, nasty ones. And we can't avoid them. But I think what we can do is say that we need surveillance, particularly in this illness where there potentially might be a slight increased risk of cancer. Again, that's a little bit of a, you know, shot in the dark. We don't know for sure, but regular surveillance is the important thing, with any new symptoms being investigated, any lump being looked at, and certainly for women, breast checks and cervical smears, and for men, prostate checks, bowel cancer checks for those where there's a strong family history. I think cancer is very, very common. You know, they say up to 2 in 5 people are going to get it. So we can't avoid it probably, much as we would like to, but we can be watchful. And I think that's the important thing. Okay. And the other one was how to avoid anxiety, was it?
Yeah, what to do about a lot of anxiety.
Oh, what to do about it, yeah, because we can't avoid it, can we? We all get anxious all the time about this, that, and the other. I mean, I'm anxious that my screen is going to die on me at any minute. So,
yeah, I know.
So anxiety is part of life. And actually, a certain amount of anxiety is probably very good for us, because it sort of keeps us on our toes and keeps us alert and watchful for danger, and so on and so on. But I think the most important thing to say is anxiety, if it's over the top, is going to aggravate one's health. It doesn't matter what's wrong with you. If you're anxious or depressed, your health will suffer. And anxiety means that you produce quantities of adrenaline into your system during an acute anxiety phase, and you feel very nervous, you have a racy heart, you sweat, you have a dry mouth, your bowels erupt, and so on. So the symptoms of acute anxiety are very well known to all of us and very common, but I think it's really important to you know, address these things. And the surest way of dealing with anxiety is to recognize why you're anxious, and obviously work on dealing with the things that are creating the anxiety. I mean, that's number one. And that might mean you need some counselling help of a professional nature, or just talking it through with your spouse or your mum or your child or what have you. In other words, bringing it out in the open is half the battle with anxiety. But a lot of people do need medical treatment beyond just talk therapy. So you might need to learn some good relaxation skills. You might need to be thinking in terms of, you know, nice things like treats and massage and so on and so on. But a lot of people will need medication, and we prefer not to use medication which is habit forming, like the benzodiazepines like Valium and lorazepam and so on, because they are habit forming and they're not very good for you in the long term, but taken occasionally are fine. So you might be going through a major sort of anxiety crisis, and you're not sleeping and your health's getting worse, and so a week on something like Valium is not going to be the end of the world, and it might just see you through quite nicely. But more importantly is addressing the underlying cause of the anxiety, which may in fact be the illness itself. But the more you talk about it and face it, the better your chances are of overcoming and dealing with it.
Absolutely. Absolutely.
Okay, so should we think about calling a halt before people totally flag away here? I think we
I've
could
got a
probably go
few
on
that
for
look a bit, few that look a bit sleepy.
It was just one question there that I thought was very important was, could you name the 2 drugs to increase blood flow? You named 2 drugs. What were they?
Well, nimodipine and nifedipine.
Okay, I'll end the questions. There's buckets of questions. I could keep going on, but it's very difficult for people
Yeah,
to.
I think we'd need an extra hour and a half to go through
I know,
the rest
yeah,
of them. So
yeah.
Well,
sorry,
yeah, we'll start again tomorrow.
we'll do it again. We'll do it again. So sorry to everybody who couldn't get their question answered, but you know, there was a lot of them. So once again, Dr. Vallings, thanks very much indeed for coming and giving your talk tonight. It was very enlightening. Thank you indeed.
Absolutely. Thanks a million.
Well,
Ross.
thank you.
Thank you so
I think
much.